Well, everyone can hear me okay? Everyone in the back can hear me? Okay. Well, I'm truly honored to have all of you here tonight. Been doing this for a few years. This is the most people I've ever seen, so hopefully you will enjoy this topic. I knew it was something when they asked me to give a lecture every year. I tried to think of one, not only myself as a doctor, but as a person and a human, and things that I would want to know. So here we go. So I chose to talk about supplements and cardiovascular disease. I think every one of us at some time has taken some over-the-counter supplement medication, and it turns out that about 2/3 of Americans take a supplement. And it's a huge amount of dollars. So there's almost $122 billion a year that is wrapped up in the supplement industry, which makes almost 1% of our gross domestic product. On top of that, the supplement industry comes up with about 750,000 jobs a year. One of the things that I always think about in my practice when people ask me about supplements is, how are they regulated? I mean, we know that there is a very specific and stringent process with the FDA for pharmaceuticals, but some of my concerns when I tell people to take supplements is how do you know you're getting a pure supplement? And so I went back and researched, what are the regulations? And it turns out until about 1994, there really weren't any. Okay, so you could market anything you want as a dietary supplement, and there was no FDA oversight. And then about 1994, they started to realize maybe that's not such a good idea. And there was a lot of lobbying in Congress, because you can see the number of dollars that are associated with this industry. And eventually what they came up was what's called this Dietary Supplement Health and Education Act, which was signed by President Clinton. And that basically said that if you had a supplement that you marketed before 1994, you're good. You can keep marketing it. There's no oversight that needs to happen. But anything new that comes forward after that date, you have to write a letter to the FDA explaining why you think it's safe and giving them a rationale for why it's safe, and then you can go ahead and market it. But this is not the same process that pharmaceuticals go through in terms of ensuring that the product is pure and not contaminated. So some oversight, but nowhere strict as near the pharmaceuticals. So I started thinking about my practice, when patients come in to see me, what supplements do they bring in? And these are the ones that I get. I get vitamin D a lot because that's a common thing, especially up here in Tahoe where we go through periods of time where you don't have as much sun exposure. I get the fish oils, the omega-3 fatty acids. Calcium, particularly in the older patients who are taking calcium for prevention of fractures. They are always concerned about the heart risk with that. And then I get CoQ10 and red yeast rice. And those were the big ones that I wanted to focus on tonight. And if any of you have any other particular ones you want to ask me afterwards, I'll try and do my best to answer those questions as well. So let's talk about vitamin D. Vitamin D is a fat-soluble vitamin, so there's A, D, E, and K, which are fat-soluble vitamins, and the term vitamin is somewhat of a misnomer because you make vitamin D, okay? You make it from your skin. And a lot of people think vitamin D should be more of a pro-hormone, meaning that it's a hormone in your body as not much as a vitamin. You can get vitamin D from intake, so there are some natural foods that contain vitamin D, but there's not a whole lot. Sometimes fatty fish, particularly if you're into the flesh of a fatty fish, and then beef, liver, cheese, egg yolks have a form of vitamin D that you can naturally intake. But most of the vitamin D in our diet is from fortified foods, and actually this is when they started fortifying milk, which helped to cure people of Rickets disease many years ago. You want about 400 to 800 international units a day of vitamin D. Those are the recommendations. But you can get vitamin D from sunlight, okay? So most people get the vitamin D that they need by synthesis of it in your body. You get it from ultraviolet light, ultraviolet B, in a certain wavelength. You're supposed to spend, very specific, 5 to 30 minutes between 10 a.m. and 3 a.m. twice a week, and face, arms, legs, or backs. And you don't want to have sunscreen on that area to allow the UVB radiation to synthesize the vitamin D. Now, of course, that's going to be affected by a number of things, what season you're in, particularly, obviously, winter, you're going to have less exposure, the time of the day, the length of days, cloud cover, smog, the darker skin pigment, sunscreen use, etc. Anything that blocks the UV radiation to your skin will reduce the level of synthesis in your body. Now, although we're advocating UVB radiation for synthesis of vitamin D, you also have to balance that against the risk of skin cancers from excessive UV radiation. So here's the vitamin D, all right, just to go over everything. So 7-deoxyhydrocholesterol is the cholesterol molecule in your skin that with sunlight gets converted to D3. You can also get it from the egg yolks, the fatty fish. You can get it from fortified foods. But the vitamin D that you take in is inactive. It's not ready to go. It has to go through a series of steps in your body. So the first is in the liver, and it gets what we call hydroxylated, which makes 25-hydroxy vitamin D. That's what we test for in your blood. Okay, when you get your blood vitamin D tested, and this one, we use that because it's pretty stable. Now, you can't overdo it with vitamin D. So from sun exposure, at some point this process sort of plateaus. But you can overdo it from intake of vitamin D. That one is not as regulated as closely by the body. So from this 25-hydroxy vitamin D, it goes through another step in the kidneys where it becomes the active vitamin D that circulates its effect in the body. Well, what does vitamin D do? Well, we know that it's important for bones. So you take the vitamin D, and its main function is that it causes you to absorb calcium and phosphorus, which are responsible for forming bone, and also magnesium and zinc. Now, if you're deficient in vitamin D, you get rickets. And that was nearly a century ago. No one sees rickets anymore except in third world countries because we know that vitamin D is important. But as you get older and your vitamin D levels get deficient, then your body starts to chew up the bone and to maintain adequate calcium levels, and you can get osteomalacia, which is soft bone, which can lead to fractures. Now, what about the heart? Well, it's not as clearly defined what vitamin D does as we know for bone, but here's what they think. They think that vitamin D is responsible for blood pressure. So there's an intricate system in your body which we call the renin-angiotensin system. And what it does is it controls how much salt and fluid you absorb back in to expand your bloodstream and how constricted or tight your blood vessels are. And when you're deficient in vitamin D, that system is not regulated, and it causes you to get too much fluid in your body and constricted blood vessels to raise the blood pressure. So maybe there's a correlation with hypertension or high blood pressure. We also know that vitamin D has a lot of these receptors on the inside of your arteries, so maybe it helps control the constriction and dilatation of the arteries on what we call endothelial or inner lining of an artery layer. When you're low in vitamin D, then you get low in calcium. And then we know we need calcium to make your heart muscle contract, so maybe the heart doesn't squeeze as well. When you're low in vitamin D and low in calcium, you get release of a hormone called parathyroid hormone. And those of you that see Dr. Cottrell for your bones will know a lot about the parathyroid hormone. But parathyroid hormone causes your heart muscle to thicken. So if you have high parathyroid hormone levels, your heart muscle gets thick, which is dangerous. You don't want that. And then there's also some thoughts that maybe vitamin D helps with your body's management of glucose. Maybe it helps insulin secretion. Maybe it helps your body process the insulin that you have. So what's a normal vitamin D? Well, this is not as clearly defined as you would think. I mean, one society versus another has varying opinions of where your vitamin D should be. It turns out that anything less than 20 is considered deficient. And we know that you probably need something greater than 20 on your blood test just to maintain adequate bone health. The desirable range is probably somewhere between 20 and 50. But if you get over 50, some people think maybe that's too high. Your labs usually, when you get your blood test if you've gone to see your primary and they've measured your vitamin D, they usually use 30 as a cutoff, and that seems to be sort of universally accepted. Some people think that's too high, but 30 is what we tend to report. So if you're less than 30, you're considered insufficient. If you're less than 20, you're deficient. But 40 to 50% of adults, if you use that cutoff, are either going to be insufficient or deficient in vitamin D. So why do you care about vitamin D in your heart? Well, they began to figure out many, many years ago, almost a decade ago, that people who had vitamin D deficiency were clearly at an increased risk of heart disease. So what I've shown here, not to bore you with too many statistics, but I think it's the best way to demonstrate it, are Kaplan-Meier curves. So we use these in cardiology a lot to demonstrate time to an event. So On the y-axis here, you have probability of cardiovascular disease, and on the x-axis, you have time, which is in years. So if you look at two patient populations, so the solid line are those who had normal vitamin D, and the dashed line here are people who are deficient in vitamin D, you can start to see over time that there becomes a higher probability of cardiovascular disease, whether that's heart attack, stroke, or death. What was most striking, and it kind of goes back to what we were talking about, maybe vitamin D is involved with hypertension, is that if you look at the subset of patients who had hypertension along with deficient vitamin D levels, a strikingly increased risk of probability of cardiovascular disease. These are what we call risk ratios. So what's happened is now that we've had sort of a decade of looking at this, is there's been study after study that have looked at it, and then someone goes and does what's called a meta-analysis, where they read all the studies and analyze all the statistics and produce you one graph which shows you the summary of all the individual studies. So you basically have a middle bar here, and on this side, you would say you are at lower risk of heart disease, and on this side of it, you would be at higher risk for heart disease. So these bars sort of represent the median of that study, and these lines represent the variance. And what I want you to see from this is that if you look at all of the cumulative studies that show risk of heart attack, stroke, cardiovascular death with deficient vitamin D, they all lie on this side of the curve, showing an increased risk of cardiovascular disease with vitamin D deficiency. Here was something else interesting I found. So this graph shows you your risk versus value. So you kind of like to know, well, if it's low, and maybe I'm over 40, I'm okay, maybe I'm less than 30, I'm not. And what we can see is that as you get lower, particularly in that 20 and lower, that curve starts to expand, so your risk is going up. But you get somewhere out in this range above 30 or so, and it starts to plateau. Unfortunately, we don't have as many data points in the higher vitamin D levels to give you the information like we do the vitamin D levels. So the big thing people want to know is like, okay, I get it. I'm low in vitamin D. I have an increased risk for cardiovascular disease. Give me the vitamin D supplement. I want that to go away. But that's not the case, all right? And what we know clearly is there's this inverse relationship. So the lower your vitamin D levels are, the higher is your risk of cardiovascular disease. And that is also probably true for hypertension, it looks like. If you're less than 15, you're at the highest risk. 1.52 times as likely to have cardiovascular disease with low levels of vitamin D as opposed to those in the normal range. And I have to tell you, there's a lot of people that say, well, those people are deficient in vitamin D because they're not out exercising, they're not out in the sun, they're not out and active. So there's concern on that front as maybe the low levels of vitamin D is sort of an epiphenomenon. So how do we figure this out? Well, it turns out it's hard because most of these vitamin D analysis that we get from have all been bone studies. So people have gotten calcium and vitamin D, and the primary outcomes of these studies were looking at fractures. And these weren't sort of pre-specified cardiovascular endpoints. We're sort of pulling data out of it and trying to determine whether that applies. So here's what we know. You can take vitamin D, but it doesn't seem to lower your blood pressure. It doesn't really seem to affect your cholesterol. Maybe it reduces your risk of heart failure. There's no reduced risk of heart attack. It doesn't reduce your risk of stroke. And there's no reduction in overall cardiovascular mortality. So even though I can tell you your level is 15 and you're deficient, and that's a higher risk of cardiovascular disease, supplementing your vitamin D from a cardiovascular standpoint doesn't seem to mitigate that risk. You know, please don't stop your vitamin Ds because your primaries will yell at me because of calcium in your bone, but that is the data as we have it as of 2017 as to is vitamin D supplementation beneficial from a cardiovascular standpoint. Now, of course, we always like to have trials that are purposely designed to assess a question, and that's the main focus of it. And the best one that I can see that is going on is called the VITAL, so vitamin D and omega-3 trial. This is 25,000 healthy middle-aged adults, which is what most people are that are taking this. They're going to get 2,000 international units of vitamin D daily with and without omega-3 fatty acids. And we're going to look, what's the incidence of cardiovascular disease, stroke, and cancer over 5 years? And we should have that data in 2018. So there should be an upcoming update with a randomized, controlled, prospective trial, which truly will answer the question. So that's vitamin D. Let's move on to fish oils. So fish oils are these omega fatty acids. These are what we call the polyunsaturated fatty acids. For those of you I always get confused, saturated, monounsaturated, polyunsaturated. So basically when we're talking about the saturation, it has to do with the molecular structure of the fatty acid. So you have all these carbon atoms on here, and then usually these carbon atoms have a hydrogen, and if all the carbons have hydrogens, it's saturated. But you can see here this line is what we call a double bond, which meaning the carbons are attached to each other twice. And these double bonds, when there's multiple of them, make it polyunsaturated. And we give the 3 because you go 1, 2, 3 carbons in, that's the first double bond. You always start at this end. So that's an omega-3 fatty acids. Of course, there's omega-6. You go in 1, 2, 3, 4, 5, 6 carbons, and you get the double bond. So that's how we define them. These are the good fats, okay? The ones you get from the avocado, the salmon, the good fats they tell you to get are these polyunsaturated fatty acids. Well, most of the ones that I deal with are the omega-3s, okay? This is the fish oils. This is the flaxseed oil that people are taking. So you get 3 types that we use. There's alpha-linoleic acid, ALA, that's in walnuts, the flaxseed oil. There's EPA and DHA. Those are the marine-based ones from all kinds of sources: phytoplankton, algae, fish oil, fish, the salmon, the herring, mackerel, anchovies, and sardines. So great selection there. At least one of them's edible. And krill, okay? So krill oil is the other. So if you look at all the supplements that are used in the United States, fish oils are by far and away the most common. All right, so you can look at a lot of common glucosamine, melatonin, CoQ10, echinacea, ginseng, whatever. Fish oils are by far and away the most commonly used. So what are the benefits? Well, you guys can look on Google yourself and you pull up a fish oil supplement and there's a laundry list of things that they say they can do for you. And I don't know that I'm the expert to say each one of those is true or not. I can only tell you from a cardiovascular standpoint what I believe is true. Well, certainly we know they're involved in brain development and essential brain function. That's why a lot of formula is fortified with it, and people take supplements when they're children and their brain are growing. I'm hoping it helps. But look, reduce weight, waist circumference, eye health, inflammation, healthy skin, may reduce liver fat, reduce anxiety, depression, hyperactivity disorder, may reduce the risk of Alzheimer's, asthma, allergies, bone health. I mean, there are a number of things that are marketed that fish oils will do to help you. Well, what about your heart? In 2002, kind of when fish oils were becoming a much more prevalent supplement, the American Heart Association put out a statement. And they tend to do this periodically over time. And they put people into 3 populations. So if you had no documented coronary heart disease, they would say it's probably a good idea to eat fish twice a week. Okay, so that's where the incorporation of fish into your diet, particularly the salmon and the others, became prevalent. If you have heart disease, so you've had a heart attack, they want you to get about 1 gram a day of the EPA and DHA, and preferably from oily fish. But if you can't do the oily fish, then the supplements were probably okay, but you should check with your doctor. For a specific type of cholesterol abnormality called triglycerides, those are the fat in your body, some people have very high triglycerides. And the fish oils can be very effective in reducing those. In fact, there is a prescription fish oil called Lovaza that we tend to use for people that have very high triglycerides. So even then we knew that, and that was recommended at that time. So how do fish oils help? Well, sometimes they think they're antiarrhythmic. So someone has a heart attack and they can have a scar in their heart, which can produce lethal heart rhythms. They think that the fish oils can help stabilize the membranes of those damaged cardiac cells and reduce their risk of having some type of arrhythmogenic death, like cardiovascular or cardiac arrest. Maybe they thin your blood a little bit because a heart attack is a blood clot that occurs in your artery, and maybe there's sort of weak blood thinners that can help prevent that. We know they lower triglycerides, so that's a good thing because having high triglycerides is associated with increased risk of cardiovascular death. Maybe they prevent the plaques from growing in your body. So cholesterol deposits in your artery and forms a plaque. Maybe they help reduce them. Maybe they're anti-inflammatory. There's a molecule called nitric oxide which is released in your blood cells. So your artery cells are not just, they're living in organisms, and they produce hormones that cause them to expand, and nitric oxide causes the arteries to dilate. Maybe it helps with that. And maybe the fish oils can lower your blood pressure a little bit. These are all the postulated mechanisms of why they may help these patients who have cardiovascular disease. Well, a decade and more goes by, and it's time for another scientific statement because fish oils become more and more prevalent. And this is again from the American Heart Association. Here's our primary prevention group. So these are people that have no prior heart attack. Okay. Use of omega-3 supplements in the general population without coronary heart disease. There's really no trials. There's no data to pull from. I don't have prospective trials. That's why we're waiting for that VITAL trial. So there's no information, there's no hard science, evidence-based science for me to tell you about that. So we can't make a recommendation. Probably isn't going to hurt you, but I don't have any evidence to tell you that it's beneficial at this time. What about patients that are at high risk? So you've had a stroke, maybe you've got problems in your legs, you got peripheral vascular disease, you got diabetes, you got high cholesterol. Is taking fish oils good for me? Well, it turns out there were 4 clinical trials, and there were mixed results. 3 of them said there was a benefit, no benefit, One of them said there was a slight benefit. So in cardiology, we kind of give things levels of evidence recommendation. So class 1 would be overwhelming evidence to do it, it's good for you. Class 2 would be, sometimes there's evidence, sometimes not. And class 3 would be, no, don't do it. And within each class, we kind of do an A or a B. So A would be higher end, B would be lower end. So this sort of falls, if you're high risk, into the 2B, like, maybe there's some evidence, but it's not really strong, to, nah, it doesn't look like it's supposed to help you at all. Okay. Now what about the high risk patients? What about the ones that we knew in 2002 that we think it would benefit? Well, it sort of stayed the same. So there's been 5 trials that have completed, because this is a much higher patient risk population. Not a high level though, only 1,000 milligrams a day. Most people tend to take a higher dose of that. Maybe it reduces the coronary heart disease death risk. Okay, that's the big benefit. And that's what we saw in 2002. Those were the patient population we were targeting. And again, they think it's probably related to a reduced risk of death from what we ischemic heart disease, so a heart attack and a arrhythmogenic episode. Doesn't reduce the risk of recurrent heart attack in these patients. We do think that the benefit of the fish oils tend to outweigh the risk, so we're going to give that a class 2A. All right, that means there's some good evidence, and most of us are in agreement that if you have had coronary heart disease before, that this may be beneficial for you. One of the things that's really interesting as I started going through this data is as you look at the older trials, the ones that were done 10 years ago, and the benefit is overwhelming. It's much higher than the ones we're seeing in the recent trials. Well, how can that be? And we think it's because we're better at it now. So we're better at telling people what to eat. So we tell people, you need to intake things like the Mediterranean diet, and make sure you're shifting away from trans fats and saturated fats and into the polyunsaturated fatty acids, because those are beneficial. We're better at treating heart disease now than we were 10, 15 years ago. So people, when they have a heart attack, we put a stent in, which mitigates the heart damage that we used to get. And we also have better medications. So we have people on statins to control their cholesterol, beta blockers to lower their blood pressure, aspirin to to help reduce the heart attack risk, and ACE inhibitors, another type of blood pressure medication. So our medical therapy is better. So maybe the benefit's still the same. We're just not seeing the same risk reduction as we used to, because we're better at taking care of heart patients than we used to before, and telling you more about your lifestyle than we used to be able to 15 years ago. Let me go back here. A couple things I just wanted to mention real quick. So here were a couple other interesting data points. There's no benefit in secondary prevention. So if you've had a stroke, it doesn't help you prevent you from having another stroke. And we also fibrillation, all right, very common irregular heart rhythm. People always ask me, well, if it helps with arrhythmias, maybe it'll help me from getting an AFib episode, and it doesn't appear that there's a lot of data to support that. One outlying factor was people that have heart failure with what we call reduced ejection fraction. So the ejection fraction is how much of the blood is pumped out with each heartbeat. And when you have heart damage or a heart attack, it lowers because you've lost some of the heart function, and we call that heart failure with reduced ejection fraction. And maybe people taking fish oils in that population, it can help reduce your risk of hospitalizations from congestive heart failure. There was one study that showed about an 8% benefit, but that was the only one. All right, calcium. So calcium is obviously essential for maintaining bone health. You go to your primary care as you get older, they want you to take 800, 1,600 milligrams a day of calcium plus vitamin D for your bones. Whether or not that helps prevent a fracture is a whole nother lecture that I'll defer to them, but commonly used. And calcium does all kinds of things in your body. Contraction of the blood vessels, relaxation of the blood vessels, function of muscles, functions of nerve transmission, hormone secretion, so there's all kinds of roles for calcium in your body. But 50% of older men, 70% of older women are using calcium supplements for prevention of fracture. And I get a lot of people that come in and say, well, geez, I read on the news, like, I see that people who take calcium may be at higher risk of heart disease, and I'm taking this calcium. Is this safe for me to take? So let's take a look at it. Here's more of your favorite statistical curves, but I think they're important to see. So this is from the British Medical Journal. And this was the effect of calcium supplements on risk of myocardial infarction, which we call heart attack, cardiovascular events. Again, so this is cumulative risk of heart disease, and this is time. So the people in red get the placebo, which is kind of the sugar pill, and the people in blue get the calcium. And everyone can see right here, so risk of myocardial infarction, heart attack, is higher in the patients who are taking calcium. And the risk ratio of 1.31 means that they're about 31% more likely to have a heart attack. Doesn't seem to translate for stroke, doesn't seem to translate when you combine all the endpoints of heart attack, stroke, or sudden death, and death look to be similar as well. So there was this signal here that maybe taking calcium increases your risk of heart attack. However, it's maybe not as clear as we thought it was. And sometimes it's hard in medicine because statistics can be so misleading, all right? But here was the Journal of Bone and Mineral Research, and basically we're looking at those risk ratio plots again. So if it was truly that taking calcium would increase your risk of heart attack, we'd expect all of those boxes to be back over on this side. And what we find is they're all right in the midline, which doesn't really tell us anything. It's not statistically significant. They need to be over on this side, and hopefully those bars that are associated with them over on this side as well, to really good inference of the data. So what can I tell you? After reading through all the data and reading through the most recent review, which was published in the Annals of Internal Medicine, if you're taking 2,000 to 2,500 milligrams a day from food or supplemental calcium sources, it's not going to increase your risk of heart attack as long as you're a generally healthy individual. Okay? You start exceeding excessive amounts of calcium, I think there is some concern for increased risk. I did have one patient who was fearful of her bones and was taking an incredible amount of calcium supplementation and did develop calcification of one of her heart valves, which had to be replaced. But I think as long as you are staying within that range, which I believe is where most people are when they're taking a calcium supplement prescribed by their physician, that you should be totally safe based on the data that's available. All right, CoQ10. CoQ10 is the short name. The big name is ubiquinone. It's what we call a coenzyme, so it's involved in biochemistry and making energy for your body. And certain organs that have a lot of energy requirements tend to have higher levels of CoQ10 in them, and one of them is the heart. Also, sometimes we know that CoQ10 can be depleted in the body, and probably the biggest culprit of this are the statins. So this is why we think sometimes people get muscle aches and muscle inflammation from the statins. Is it because it reduces the ubiquinone in the muscles, which makes them weak and inflamed? It's not approved by the FDA for any treatment of any medical condition, but it's generally well tolerated. Most people don't come in and tell me that they're having any side effects from their CoQ10 supplements. But just for thoroughness, I put on there, here's the things that can be seen: nausea, vomiting, appetite suppression, stomach aches, rashes, and headaches. So is there any benefits? I personally only use CoQ10 for people who are on statins. Okay, and I don't do it for everyone, but when you get someone that's kind of, had a heart attack and there's overwhelming evidence to reduce their cholesterol with the statin, and they're starting to get muscle aches, then I usually put them on CoQ10 because I personally believe it helps. Somewhere around 200 to 300 milligrams a day. We combine that with fish oils, the 2,000 milligrams a day of fish oils, because the two of them seem to have an anti-inflammatory effect for people to take the medication. But I don't have any data to support that. That's sort of my way of doing it. There's no data to show it helps you in heart failure. There's no data that shows that it prevents you from developing heart disease. No data to show you that it lowers blood pressure. Okay. For people who take Coumadin, which is some patients in the population, it can interfere with your Coumadin levels. So if you do start that supplementation, it's really important for you to let your physician know who's managing your Coumadin, because it can alter your levels. The final one I want to talk about is red yeast rice. I spend a lot of time talking to people about this because people really hate the statins, because there's so much marketing that goes on out there about, are statins safe, are they not safe, and people are always looking for a homeopathic or a natural way to lower their cholesterol. And red yeast rice is probably the biggest one. Red yeast rice is a Chinese medication, and it comes from fermented rice. So there's specific fungus or mold that grows on this rice that produces a compound which is called a monocolin. And this monocolin K that it produces is molecularly almost identical to lovastatin, which is one of Mevacor, which is one of our statins or cholesterol-lowering medications. In fact, it's so close that the FDA has been all over this supplement because they're concerned that you're marketing this supplement, which is so close to a pharmaceutical. And it gets banned, and then other companies make it under a different name, and then they catch that one and it's banned. So I don't know that I could tell you a company that's out there right now that is producing this active monocolin to the degree that you need it to reduce your cholesterol. It has to be somewhere around 2 to 3% monocolin K to be able to have an effective reduction on your cholesterol. But if you can get the right one, it works. And I have patients who have gotten the right one and it has worked. You usually take about 2,400 milligrams a day, and it can reduce your LDL, your bad cholesterol, up to 22%. But the problem is there's no purity, there's no assay. You can't tell what active ingredient of this monocolin K you're going to get when you purchase this over-the-counter supplement. So certainly using a health food store like maybe Grassroots or something where they have a bit more information on the supplement may be beneficial and something you would want to ask them. You need to be a little careful though, because sometimes with these red yeast rice, they can have toxins in them, which can be dangerous to you because they're, the mold and the fermentation process. So make sure I just wouldn't randomly pick up red yeast rice and start taking it. I try and get it from a reputable source and make sure you're aware of the monocolin content and the potential for toxins. All right. Well, that was a lot of information in a short time, but I want to kind of cap off what I think are the highlights from all this data. We know vitamin D levels less than 20 increase your risk of cardiovascular disease. I think there's pretty good data to support that, and most people wouldn't dispute that. The problem is we don't have a lot of good data to say that taking the supplements reduces your risk of cardiovascular disease, and hopefully that Vital D trial will help shed some more light on this. If you have had coronary heart disease, so you've had a heart attack before, there does appear to be good data to taking at least 1,000 milligrams a day of omega-3 fish oils may help reduce your risk of death from heart disease. Calcium supplements of 2,000 to 2,500 milligrams a day are probably safe and healthy for you in terms of prevention of fracture and should not increase your risk of cardiovascular death. CoQ10 helps me in patients reducing the side effects of the statins, but as of the literature, there isn't a lot of other cardiovascular risk reduction benefits from it. Red yeast rice, as we just talked about, can be an effective supplement to reduce your cholesterol, but keep in mind it's got to contain the monocolin K, the active reduction molecular structure that's similar to the lovastatin. And with that, I think I'm going to stop and open up to some questions. Yes?
Would you recommend the CoQ10 with the red yeast rice since it's like a statin?
So I'm going to talk about statins. It's always when people come in and so let's backtrack a bit. So first thing you got to realize about whether or not to take a statin is, do you need to? And there are published guidelines for who should take a statin and who shouldn't. And that is all dependent on your 10-year cardiovascular risk. So I think part of the problem we got into in medicine and in cardiology is we told you statins are great, everyone should take a statin, it's going to make you live forever. And that's probably not true, because we're giving people with such low risk of heart disease a medication that the risk of the medicine probably outweighs the benefit. So unless your 10-year cardiovascular risk is over a certain point, then there's probably no reason you should be taking a statin. And diet and lifestyle are still the most important things to reduce your cholesterol. For the people that are at high risk, and there's 4 subgroups that we use, and we prescribe a statin, I almost hate talking to people about the muscular side effects because everyone calls me, it's like my joints hurt. I'm like, well, you probably worked out, you're sore. So the published incidence of muscular side effects from the statins is not supposed to be more than 5 to 10%, okay, at max. And they've actually done some really elaborate studies where they've taken people who said they're statin intolerant, and like 50% of those people truly weren't statin intolerant. They didn't have any muscle problems. So it's a widely overpublished side effect. If you fall into a risk category where your 10-year cardiovascular risk is over 7.5%, then I would tell you that your first choice is to take a statin. And you don't have to take 80 milligrams of Lipitor in most cases. You're just trying to reduce your LDL cholesterol by, say, 30%. There's nothing wrong with taking CoQ10 and a statin together at all. In fact, in Europe, I think they do it pretty consistently with people that they prescribe statins. I don't know how to advise you on red yeast rice and CoQ10. I don't think it's going to hurt you. Let's put it that way.
Thank you.
Okay. Yes?
Can you take the red yeast rice? You said that there's a toxin in it or something? Or
There can be. Okay, so it just goes back to the fact that these medications, red yeast rice, I believe, has been around for a long time and is not regulated. So the purity is an issue of it.
So what about people who have immune problems or something? Do you suggest that they would take that if they, they always say, don't take this if you have?
I don't think it's, I very rarely will put people on red yeast rice. I try and convince them, and I give them the material and information available to have them on a statin. I would say if there were any concerns that you have an immunocompromised body, then I would probably not put a unregulated supplement into it. No, I would not do that for the risk. Yes, sir.
You hear a lot about krill oil in
Yeah.
the fish oil.
Well, krill oil it falls in the omega-3s, and one of the concerns we had about the omega-3s is that companies that were mass producing them, the bigger fish you get, the more omega-3s you get. But the problem with the bigger fish is you get higher levels of mercuries and heavy metal in the fish. So krill oil, as I understand it, still contains the omega-3s, but you have the lower risk of containing the heavy metals in the krill oil.
So that's all it is. Okay.
Yeah. I read somewhere along the line that there's a problem with overfishing krill now because everyone wants the krill oil, but I can't attest to it. So, yes, ma'am. Okay, that's a great sub. So low dose aspirin, 81 milligrams a day. So you have 2 groups, right? You have primary prevention and secondary prevention. So primary prevention of heart attack, stroke, or cardiovascular death with aspirin therapy alone is again based on your 10-year cardiovascular risk. And I believe the United States Preventative Task Force says if your 10-year cardiovascular risk is over 10%, then you benefit from 81 milligrams daily. Anyone who has had a heart attack, stroke, peripheral vascular disease for secondary prevention should be on 81 milligrams a day of aspirin. Now, what goes into that calculation of your 10-year cardiovascular risk is your blood pressure, your age. Your age is probably the biggest driving factor, whether you're a smoker, diabetes, gender, and I think that's it. And you can calculate that online. If you type in your 10-year AHA, American Heart Association, cardiovascular risk, as long as you know your cholesterol and blood pressure from a blood panel, your wellness labs, then you can calculate that yourself and read all about it. And it'll tell you when you do it, you do not need to be on a statin, you do not need to be on an aspirin, and your blood pressure looks good. Or if you're having problems in there, it'll tell you, you should benefit from one of these therapies. You can calculate that on your own.
What about when your doctor puts you on 320?
Well, so there's different indications for 325. Okay, so sometimes we use higher doses of aspirin for people who have had a recent heart attack. So what aspirin does is aspirin inhibits a blood cell in your body called a platelet. So you have these blood cells called platelets that circulate around, and when your blood vessels are injured, they stick to it and start a blood clot. When you have a heart attack, what happens is the cholesterol plaque in your body breaks open, and it spills all this cholesterol material into the bloodstream, and those platelets come and stick to it, and it starts the blood clot in your artery, which makes the heart attack. So we use the aspirin to make those platelets less sticky, so that if that cholesterol plaque breaks open, they don't stick to it and form the blood clot. And sometimes we use higher doses of aspirin if we want those platelets more inhibited than others. Yes?
Do you have a favorite brand for supplements or vitamins?
I don't. For fish oils, I do. I tend to ask people to use the Nordic Naturals. I think that's a good brand of fish oils. I heard on the news that there's the doctor's favorite coenzyme Q10, like ubiquinol or cardiology approved. I don't, I try and tell people to go to a place that's at least reputable, so someone's doing some research along the line as to, okay, this is a good company, this is not. I will tell you, in medical school, none of this is taught to us. We learn traditional pharmaceuticals, we learn about beta blockers and statins and the whole supplement industry and homeopathic approaches to medication is not taught in traditional Western medical schools. So, I don't. But, yes?
Can you explain the thought process behind recommending CoQ10 so widely in the medical community, even though there's no academic
It's a lot of money.
support?
There's a lot of money in it, and like I said, this is the data that I was able to extract, and I was trying to give you evidence-based literature. Okay, so I try and do that with people, because to me, no one wants to take a pill every day. It's annoying, and you don't want to do it. So I try and say, if you take this medication every day, this is what you're going to get. This is why you're doing it. So you're taking this cholesterol medicine because I can tell you you're going to reduce your risk of heart attack or stroke by 40%. And that data is not out there for CoQ10. Just couldn't give it to you. Well, thank you. Thank you. Oh, sorry. Yeah.
The flaxseed.
Yeah.
Now, I know that you probably don't have the risk of mercury with that.
Yeah.
What about milled flaxseed, or does it need to be the flaxseed oil? Because don't you get the oil with the milled flaxseed?
I don't know the answer to that, to be honest with you. Flaxseed actually has really high concentrations of omega-3s. There was a chart I almost put in here that had all the different foods and stuff and the omega-3 concentrations, and flaxseed's at the top.
And would that be the grain itself? Like
I think it was the oil, flaxseed oil that I looked at. I don't know about the grain.
Okay.
I don't know. I think it was the oil that they use, so I know the oil for sure, but I'm sure the grain is great too.
So people can't take the omegas because like they get the birds or something from it?
Yeah, I mean that's the problem with the fish oils, and there are some. The Nordic Naturals to me tend to be a little lighter on people's stomachs, so you don't get that awful burp, an hour later after you take it. But flaxseed oil is fantastic. There's nothing wrong with that. Yes.
We always tell people going through surgery to stop their vitamins, supplements, especially fish oil
Yeah.
and garlic. Is that evidence-based?
Well, the garlic I don't know about, but the fish oils, yes, they are concerned, and that's maybe why we think maybe they're helpful, is because they're that anti-thrombogenic. They help thin the blood a little bit to reduce your risk of heart attack. So I don't think that's a bad idea at all to stop the fish oils because of the potential for them to be a weak anticoagulant, kind of like you haven't stopped the aspirin, Yes.
I was just wondering, in the people that they use in these studies, because I attended a conference at BC Medical Center, and they stated that just 20 minutes of secondhand smoke would cause your blood platelets to become so sticky, that's in a non-smoker,
Yeah.
you could have a heart attack. So I was wondering, in people, you were talking about 2002, and I can't remember what year, smoking was banned from indoors, but would there be any correlation with that? I mean,
I don't know. I mean, certainly
secondhand smoke anymore?
don't smoke is the number one thing. Please don't smoke. Yeah, the secondhand smoke is a major problem. So cigarettes do horrible things to you. So not only do they make your platelets sticky, they starve your blood cells from getting oxygen, and they constrict your blood vessels. So you deliver less oxygen to your heart through a constricted blood vessel with stickier platelets. I don't know. I don't know how to answer that. And
You don't know whether the study included people.
I don't know whether the benefit that we, from the earlier benefit that we saw had to do with less secondhand smoke exposure. But secondhand smoke exposure is just as bad as firsthand smoke exposure. Yeah. Yes.
Celebrex or Mobic? Any
Yeah.
comments on the dangers?
So Celebrex is what we call the Cox-2 inhibitors. So we thought these were the best things. So, a lot of people have arthritis. And so, we give them anti-inflammatories to help with the arthritis. But if you take Advil or ibuprofen, Motrin, any of those, they're non-selective, okay? And we know that ibuprofen, Advil, those medications increase your risk of heart attack and stroke. In fact, if you look on it, there's a black box warning on those medications. So they came up with the second generation, the Cox-2 inhibitors they call it Cox-2 because of the enzyme it inhibits, and it's supposed to be purely selective for the area that's inflamed, so you don't get the other undesirable side effects, whether it's the increased risk of heart attack and stroke, whether it's the ulcerative disease in your stomach. It was just supposed to target the area of inflammation. And there were multiple brands that were put out. There was Bextra, there was Vioxx, there was Celebrex, and I may be even missing one. But it turns out, and a lot of this came from Cleveland Clinic, is that people were dying because of these medications. And so they pulled a number of them off the market. Vioxx, I know, was a big one. Bextra, I think, was pulled off the market. Celebrex has remained. Celebrex, it looks like if you're taking 100 milligrams a day, you're probably okay. 200 to 400 milligrams a day starts to show that increased cardiovascular risk signal. So if you're going to take Celebrex, I would only take 100 milligrams a day.
Is Mobic better than, is that a little safer?
I don't know about Mobic. All of the anti-inflammatories that you use, the theory is that they raise your blood pressure. Maybe that's some of the side effects of the medications. That's how it increases your cardiovascular risk. So all of them have a adverse cardiovascular safety profile. It's tough. I mean, what do? You got arthritis, and the last thing we as physicians want to do is get people hooked on opiate medications for pain control. But sometimes it's tough when all you can tell them is Tylenol for arthritis. So.
What are your thoughts about Aleve?
Aleve is, I consider the lesser of all evils. But still, it's the same thing. It's a non-steroidal. All right, so there's still the risk of the side effects of the non-steroidals. But Aleve, out of all of them, if people have to take some time, I try and tell them to take the minimal dose of Aleve. I think a single tablet's 220 milligrams, to take that once a day. What you don't want to be taking is ibuprofen and Advil multiple times during the day. All right. Well, thank you. All right. Appreciate your attention.